Welcome to you, Walter Baynard, who is the Director of Oncology at North Florida, and today he's going to talk to us about prostate cancer and breast cancer. So let's give him a hand as he comes. Thank you.
Now, my voice normally carries, so I normally don't use a microphone. Can you all hear me? Okay, good. So, my name is Walt Baynard. I'm the director of the Cancer Center at the North Florida Cancer Center. And I'm going to give 2 talks to you today about one first, we'll do breast cancer awareness, and then prostate. Okay, what is breast cancer? Well, I got to get out of the screen here. Breast cancer is an uncontrolled growth of breast cells. A tumor can be benign, which is not really dangerous to your health, or malignant, which can be hazardous to your health. The term breast cancer refers to the malignant tumor that is developed inside your breast. So, there's been a lot of talk about genetics. For breast cancer, about 5 to 10% is relegated to genetics, so your makeup from your family history. The other percents are from mutations throughout your life that has to go through your years of being on this earth. Okay? Things that you really can't change. Biggest fact, 1 in 8 women will be diagnosed with breast cancer in their life. Now that sounds a lot, but it's somewhat skewed because it's really related to your age because, and we'll get down further down to the slides, that there's a age from 40 to 60 where you have the greatest incidence. About 250,000 cases this year will be diagnosed from breast cancer. And about 40,000 breast deaths. Okay, so that's quite a substantial number. The good news, too quick. The good news is, if detected early, you have a 99% 5-year survival rate. Now, the survival rate inside the cancer arena is the test, the guide that says if you can survive 5 years without any recurrence, there's a good chance you won't have a recurrence. So 99% if caught early. So that's an important figure. And since 2000, breast incident rates have decreased. And that's mostly because of early detection. For those who didn't know, there is an incidence for males to contract breast cancer. It's 1%. Not a lot, but it still exists. It's something that a lot of people just discount. I actually have my uncle-in-law who actually contracted it. Okay, there are actually 400 deaths per year of males with breast cancer. So we talk about the new cases related to age. You can see from 40 to 60, 69, almost 70% of all the cases. Generally, these at the young and on the older age are more severe and have a greater incidence of death because there's no. Usually by here, for the younger people, they ignored some of the symptoms, put it to something else, and it gets further along than they expected. Again, the key to surviving breast cancer is early identification, early treatment. So you can see that 40 is where it starts. Risk factors. The 2 big risk factors are genetics and age. Those 2 you can't change. But as you can see, there's about 38% of things you can change. 1, stay healthy. Stay at normal weight. Don't drink alcohol. Don't smoke. Be very active. And for those who are childbearing age, breastfeed your children. So here's a depiction of a breast, and to understand how breast cancer works, you have your ducts which is the traveling part for the milk for the breast, lobules, where the breast milk is produced, and then you have these series of nodes, lymph nodes. Those are the main components of the breast that are affected by cancer. Now, you do have some that are inside the fatty tissue, but they're not as prevalent. Signs of breast cancer, okay? Usually it's lumps, discharge, inverted nipples, discoloration, soreness. Those are all indications of something has changed in your breast. These are things you should be looking out for because no one knows your body better than yourself, and identifying those things that are different as time goes on and bring them to your physician is the best route for taking care of that. How do we diagnose breast cancer? Okay, first thing is at the user level, yourselves, you identify something unusual about your breast. Your medical history may be that your family members have a history of breast, or you may have had some genetic testing that says you have the markers that suggest you may or have a chance of getting breast cancer. So the physical exam by your physician would be the next step. Once you identify that there's a suspicious area, you'll get some diagnostic tests. And then finally, if the diagnostic test proves to be somewhat positive, or even sometimes questionable, then sometimes they'll request a biopsy. Imaging tests. You have ultrasound, over here, you have diagnostic mammography, and MRI. Those are the three most used tests for diagnostic purposes. Now, remember I showed earlier that at age 40, the incidence of breast cancer increases. So there has been, over the last 10 years, remember about 10 years ago, they suggested that women at age 50 start getting a yearly mammogram. Now they're going down to 40. And they say it's yearly because statistics show that if you do it, let's say, age 40, and wait to age 42 and miss age 41, there's a 38% chance that you've missed that cancer during that 1 year. Pretty high number for 1 year. Surgical tests. You have what's called fine needle aspiration. You have, let's say, a lump on your breast. They take a very thin needle, insert the needle, draw back some cells, take it to pathology to be determined. The other one's a core needle aspiration, where they take an actual larger bore needle, insert it in the breast, pull out a greater amount of tissue, and that gets taken to pathology to be determined. Image-guided biopsy, they will use a needle and they'll actually have either ultrasound or MRI or some other sort of diagnostic quality imaging to guide the needle to the exact spot they want. They see it like a lump on the mammography. And surgical biopsy, that is when they actually take it to the OR and actually do a surgical removal of a particular part of tissue from your body to be examined by pathology. So pathology report. This is the important part where they actually will do a tissue or cellular look at your biopsy. They'll determine the size, how quickly it grows, if it's spreading to nearby other tissues, and whether things have moved to other parts of your body. So we have four basic types of breast cancer. The first is called DCIS, ductal carcinoma in situ, which basically means that it is a carcinoma, a malignant, inside that particular area. It hasn't moved anywhere. That's 1 in 5. The next, which the IDC, is one that is inside the breast, inside the ducts that we talked about earlier. I showed you on the anatomy, and it can be invasive where it can move throughout the body. Most prevalent, that's the most 8 in 10. Will be that type. Then you have the invasive lobular carcinoma, as I showed you on the anatomy, with the milk production lobes. That is the same one. It can start there, and it can spread out also, and that is around 1 in 5. The last one, inflammatory, that's where your breasts become very inflamed, red, they get dimply appearance, and they become hot to feel, and that's a low incidence, that's about 1 in 3%. So when you hear about breast cancer, and especially those who have been diagnosed, you hear about the stages. You know, what stage am I? Okay? And there's rules that the physician uses to determine what the stage is, and generally it's determines the size, where it is, and how far it's moved through the system, especially through the lymph gland. So, like stage 0, it's just inside the breast tissue itself. It hasn't gone anywhere except for the tissue itself. So that's the most curable, almost 99% curable, caught at this stage. If one that's a small tumor, hasn't gone to the axillary lymph nodes, so that's 1. Step 2, or stage 2, you actually have the tumor about 2 centimeters, and it actually has gone into the axillary nodes. 3, tumor's greater than 2, and actually has gone through more than just the axillary nodes. And stage 4, it has gone through the entire body. Generally it goes through lung as the most prevalent, and then your liver. So what do? You've been diagnosed. What's your next step? Okay? Your physician, your primary care physician, will probably refer you to either a surgeon or a medical oncologist. And there's surgical oncologists that specialize in cancer and breast surgeons. Okay? Either one of those you'll be referred to start doing your treatment plan for your breast cancer. Also get referred to radiation oncologists. These are the 4 physicians I work with, great people. Dr. Hayes is well known in this area for doing breast cancer. Get a second opinion, okay? Your first place shouldn't be your last place to go shopping. When you buy something every day, even cars, you don't go to the first place and stop there and drop all your money in that one place. There is a difference from place to place. Every person is different, and you'll get a different feel for the physicians, for the care there, for the environment, for what's said to you, how you're being treated. Don't be afraid to look your doctor in the eye and say, look, can I get a second opinion? It's a good thing, and if they're willing, they'll even refer you to another person that you say you can talk to, because it's a good thing. Always get a second opinion. Then you have to consider what your treatment choices are. You have before surgery and after surgery. Before surgery, whether you're going to get a lumpectomy or a mastectomy. Lumpectomy is you have the tumor site, just that tumor mass is removed. Mastectomy, the entire breast is removed. Now, about 3 years ago, Angelina Jolie had made a lot of press about having both her breasts removed because of a genetic marker that said that she had a risk factor for breast cancer. So there's a large spectrum of what your choices are. You got to pick what's best for you, or what you feel most comfortable with. Your physician will give you and the medical oncologist and radiation oncologist will give you the data involved with what the cure rates are for certain types of, and what the risks are for every type of treatment. So you'll be an informed decision. After surgery, you have chemotherapy. Chemotherapy is the medication that is run throughout your body to kill the cancer drugs. Radiation therapy is very localized and only affects the areas that are being targeted by the radiation. So chemo is whole body, goes through the whole system. Radiation does not. That's why for a lot of the chemotherapy agents, you'll hear that people have their hair fall out or side effects, which may not be part of radiation therapy because, like if you're doing a breast, now your hair falls out because you're just focused on the breast. Hormone therapy, there are a lot of hormones that can be provided that will counteract the movement or the growth of the cancer cells and the growth of the cancer itself. So, once you get your treatment, you start your path to survivorship. The good part is, again, you can't see it down here, but there's about 2.8 million people right now who are breast cancer survivors. To put that in context with just the amount of people, the city of Chicago has 2.7 million people in it. And it's 3 times the size of the personnel in Jacksonville, which has got the most population in Florida. So that many people in this country are breast cancer survivors. So there is a good hope there. And down there, final thoughts. Make sure you get the right treatment for you. Go to different centers, go to different places, see what's best. There's a number of options inside Gainesville. Okay? Feel which one's best for you, because each one will have a different feel for you. You will know when you get there, you feel most comfortable with your physician, the surroundings, or what they're telling you. Everyday health. Don't be afraid to reach out, because that's where you sometimes have a tendency to kind of push people away. It's time for you to bring people in, whether it's to support groups, family, friends, and kind of share and kind of be part of your journey through this. Keep a notebook. Okay? From your day one, once you start filling a notebook full of all the things you're doing. And chronologically put that stuff in there and see what people say, because when you're in an environment where people are just throwing stuff at you real quick and you feel like you're being rushed and you want to know stuff and you really haven't asked questions or stuff, people with notebooks or have had their reports there and say, can you help me understand this? Or, hey, last week you said this, I don't understand, I was going to ask you this question, can we go over that? Do that for yourself. It'll be a good way to go back and look and see how your treatment plan goes. Check your insurance also. A lot of the treatments, like I spoke to one of the gentlemen or one of the ladies earlier about genetic testing. Now, genetic testing is becoming quite large now because they can tell you what your risk factor is for almost any type of cancer or any type of illness, just by looking at your genetic makeup. Most insurances don't pay for that. Okay? Usually have to have signs, symptoms for you to come close to be able to be reimbursed for that. But same thing with kind of treatment. So don't let your insurance company rule how you get treated. Okay, you pay for that, you find out the best way to do that, and most facilities have people that'll help you get through that. But don't let them bully you into getting something you don't want or don't need, and more importantly, don't want to wind up with. Oh, back at one. Some women with stage 4 breast cancer are still alive now after 10 years. Okay? A number of years ago, if you were diagnosed with stage 4, they gave you probably not long to be on this earth. They have now, because of modern medicines and procedures, people are alive 10 years later. So do not lose. If you ever find people that are losing hope, there is hope out there for every corner. Questions on this part? Alrighty. In the interest of equal opportunity for males and females, we'll now go to the male side. The prostate cancer. Prostate cancer is the number 1 diagnosed cancer inside males. Okay? Number 1 cancer is still skin cancer, but prostate, lung, colon, you see the incidence there. Prostate is the number 1 diagnosed cancer in males. 1 in 6 males will contract prostate cancer. I've actually even heard the comment where if you're a male and you live long enough, at some point you're going to contract prostate cancer inside the system. Okay? Real good fact is prostate can be serious, but most people do not die from it. It's a slow-growing cancer, for the most part. Now, unlike the last presentation for the breast cancer, my next slide showed that there's a 1% incidence of breast cancer for men. I will tell you that there's a 0% incidence of prostate cancer in women. So what does the prostate do? I mean, it's just out there. A lot of people don't even know what it does. So what it does is just provides seminal fluid, part of the semen. Male hormones, testosterone, actually promotes the enlargement and actually will feed the actual cancer. And as you see my little friends here, my smiley face, here you have a bladder, here you have the prostate, and that's how it sits. Right here is a pathway for your urine. With a normal prostate, with a smiley face, you've got a good pathway. When it's enlarged, it cuts that down, constricts that, and that's where you get the pain and the difficulty urinating. And here are the symptoms. Frequency of urination, interrupted urination, pain, blood, and pain in the back, radiates, and pain during ejaculation. These are all symptoms of possible prostate issue. Risk factors. Just like in breast cancer, the three big ones which are highlighted are race, age, and genetics. Now, prostate cancer, usually African American males are more prone to get prostate cancer and are actually more prone to have mortality for that. But generally, it's age, again, and genetics, things you can't change. But you can see there's a whole host of things that you do have involvement with. For those of you who would like to know that you can tell your wife's killing, another reason why your wife's killing you. Okay? Very similar to breast cancer, the same things you can do preventive to keep the cancer away. Good diet, exercise, body weight. There are a lot of vitamins that are shown to be effective to hindering prostate cancer. Aspirin has been shown in some studies, and what's called alpha inhibitors. It's a medication that's sometimes prescribed to people who have enlarged prostates, and it gives them a chance to have a better urinary flow. But that also shows that reduce the size of the prostate. So back to the anatomy part so you can understand. So here you have, like you said, the prostate. Bladder, and then you have the tube for the urine. For the seminal fluid, it cuts right through the prostate and down through. So you can see that that gland has a lot of responsibility for the excrement and matriculation of the body fluids outside the body. Okay? And if it gets swollen, that's where all the problems start. Every time I hear about a prostate, they always say the size of a walnut. So it's either walnut, golf ball, or grapefruit. All right, prostate screenings. Now you hear about all the time. Prostate screenings are usually prevalent around the area. The first one, it's called DRE, digital rectal exam. For most males who've had that done, this is the face that you usually get. He knows it's coming. Okay. You got your PSA, which is prostate antigen, prostate significant antigen, transrectal ultrasound, and prostate biopsy. PSAs. Now PSAs have come on their tack for the last couple of years. That's the blood test. And this is the reason why. When you get that test, that blood test, of all the samples, all the blue there are people that come up negative. The yellow are people that came up positive but really weren't. The gray is people that are and it didn't identify, and then that's how many actually were confirmed. So it's still used, still an indicator. It's a inexpensive way to find out, but it's not very accurate. So if you go to your physician and get a PSA score and they have you come back again and say they're going to do other tests, I wouldn't be alarmed because of this reason. Now, my father spent 25 years with an elevated PSA and never had prostate cancer, but went every year and every 3 years to be biopsied. Never had it. Other kind of late stage diagnostic exams. You have the PET scan, which is actually the bone scan, where they inject radionuclides and it'll tell you where this area of actually having cancer. And that's these dark, well, it's kind of hard to see here, but these kind of darker spots. You have CT scans, MRI scans, the normal diagnostic imaging. Here we go, the risk factors. So, when you're 45, you're 1 in 2,500 of being diagnosed with prostate cancer. Pretty good deal. But, jump to 50, drops down by 5 times to 476 in that 5 years. So when you hit 50, that's the magic number where you should be getting your PSA, your digital rectal examination, or some of these other tests to see how you're doing. And you can see incrementally it goes down almost like a factor of 4 for every 5 years. To when you get to about 76, 1 in 6 people are going to get it at that age. Types of treatments. First one is kind of just keep it on active surveillance. Just watch it for a while, see where it is. They have some signs of it, but they're not exactly sure. We're not going to do anything right now, so we'll just keep it there. Surgery, radiation therapy, cryotherapy, where they actually use cold to treat that, to kill the cancer. Hormone therapy, chemotherapy, vaccine, and bone-directed. Bone-directed is for the later stages. For one of the side of, or other ailments that happen during prostate is that you get loss of bone density inside your hips and that sort. So that kind of gives you a chance to help those out. Like I said, active surveillance is for the low risk and the medium low risk. Get a PSA every 3 to 6 months. Get your digital DRE every couple months. Just keep an eye on it to see where it goes. The good thing about doing that, just watching, is that you avoid unnecessary treatment, which does happen, or has happened in the past. Okay? And maintains your quality of life. If you discount the disadvantage, which is you're going to be nervous the entire time probably because you're always being tested for something you don't know what's going to happen. So you're always waiting for the inevitable. Radical prostatectomy removes the actual prostate gland from your body. So the 3 ways they do it. One, because by hand. I don't mean you just reach up and grab it and yank it out. I mean that's like when they say surgery, do it by the normal surgical means, by hand. Laparoscope is when they have like a particular scope to go in and has a little scissor or scalpel at the end to take that out, smaller incision on your body. And the robotic approach, which they have at North Florida, usually reserved for cancer combined for people 70 or less. Reason for that is because probably the anesthesia, it does have a lot of time involved. So as you increase in age, your tolerance for anesthesia is decreased. Recovery time is in a few weeks. And you can see, well, it's kind of hard to see here, but here's the actual patient with all the robotics, and here's the doctor on the side at a monitor. Radiation therapy. Less invasive, more trending toward people who are 70 or above because it's non-invasive, there's no anesthesia involved, it's an outpatient basis, they come in, 15-minute treatments, use high-energy x-rays, overall cure rate's the same as for surgery. For radiation, we have 2 types, you have external and internal. The external is the same thing, it's a LINAC, linear accelerator, these big machines that are inside the vaults. They produce the high-energy radiation that treats the cells. Treatment is delivered once a day for 5 days for a number of weeks. Again, it's just a 15-minute outpatient thing. You walk in, you lay down on the table, they set you up, administer the radiation, and you go out 2 minutes later. Pretty quick. Because it's a long period of time. With modern equipment, it's very accurate now. So, in prior years, they would have to give a radiation area that was a little larger, but they've had now ways to localize and target the tumors so it gets real small. So you save some of the surrounding tissues, which is very important. This is what a linear accelerator looks like. External beam, side effects, fatigue, bladder irritation, bowel irritation. That's just during the couple of times of your weeks you're there. The long-term effects, permanent bladder irritation, less than 10 to 5%, less than 5% for rectal. Impotence is probably the most prevalent for both surgery and for radiotherapy. It's about 50%. But even that is going down because of the ability to target the prostate a little closer and to save some of the other surrounding tissues. Advantages is less invasive, still no risk, very low risk of incontinence. The only problem is it's a longer treatment, but you're an outpatient, so you got to kind of weigh those two together. If you're a younger person, you got to go to work. Sometimes having that short time is a big deal. If you're retired and waiting to go to the golf course, maybe waiting 9 weeks isn't so bad. The brachytherapy, internal radiation, there's two types. There's low dose and high dose. What they do is they insert seeds inside the prostate, and instead of those seeds emit radiation and they stay inside you, and instead of having the radiation go through your body, it just stays right on your prostate. This is how they're inserted, and it's hard to see here, but there's a picture of a pelvis, and it has like around 75 seeds right there. This is the size of those seeds. That's a penny. So they're really small.
They've solved the problem of not falling out?
No. The question was, have they solved the problem of falling out? They do have an incidence. They do move sometimes. They can be urinated out, and they'll fall through the bloodstream. So there are other things that can happen. High dose, that's when you come in for about 5 treatments, twice a day, stay in the hospital. They insert these catheters. You get a high dose, put the catheters in, do the radiation, insert out, come back next time, do the same thing. One thing that most people will ask about the implant seeds is that it is radioactive and it lasts, they say, up to 6 months. So when they say you're radioactive, yes, there is a danger involved. So if you have seeds, they recommend that you don't put young children on your lap for periods of time, or have pregnant women stay about 5 feet away from you for about 6 months after you get those inserted. After that time, they're safe. The seeds, in essence, they don't go away, but the radioactive material inside decays and it becomes inert. And leaving those in doesn't bother anyone. Let's see. CyberKnife. At North Florida Radio, they have a CyberKnife, which is a form of linear accelerator or radiation that is very refined and for small, minute areas. Very accurate. But again, there's only a certain type of patients that are qualified for that. And that way, your radiation oncologist will be able to tell you if you're a candidate. Condenses 9 weeks, 45 days to a standard radiotherapy in like 3 to 5 sessions. So that's a big difference. Has a 93% control rate. So highly successful for those small tumors. And the most important, no serious side effects. So here's your treatment overview. And if you present with prostate cancer to your physician, they'll give you all these options available to you and where you are in the risk category. You can decide what's best for you. Questions from our male counterparts. The overall thing, and for both prostate and breast, is the sooner you can find out you have it, the greater chance you have for survivability. And so the hesitance is what usually takes time and puts you in a different category. So if any advice I'd give is, try to detect things early and get a treat, or see your physician early so you can get it treated early. That increases your chances for recovery. Any other questions? Well, thank you for having me.